Welcome to the Concepts of Rehabilitation lecture. I'm Dr. Tamara Hefferon, Doctor of Physical Therapy, also a board certified orthopedic specialist, also a strength and conditioning specialist. In this lecture, we're going to go over just a few of the basic concepts for rehab, just as an introduction to get us all on the same page as we progress along. These are some key definitions that I want to make sure that you guys know and understand. I'm not going to spend time going through them. You can refer back to your books to make sure that you have a thorough understanding and can discuss what each one of those is and how to apply those. So guys, what are our life goals? That's often what we need to think about when our patients come in to see us, that they're maybe coming in, they might say that their main complaint is pain, but really typically it's because there's loss of function. It's affecting them emotionally. It might affect them in their work environment. But a really good movement specialist, especially a doctor of physical therapy, will take into all of these. So what that person comes in with might not just be that person presenting with pain, but there's also that psychosocial component that you might need to think about. The social component, talk a lot about this with our geriatric patients, that really making sure that there's a social component to their life and their environment, and that you guys are really taking on that healthcare practitioner role, not only just trying to address that single reason that they maybe initiated coming to you, but their overall health and well-being. What's our role? Well, our role is not only it's to assist in helping that patient get back to what they want to be able to do. It's improving what they're coming in for. So maybe they've lost function, or maybe they're coming in because they want to better their lives. Just had an interaction with someone who wanted to begin running, but she was nervous because she was, very overweight and wanted to make sure she could do it in a safe manner so she wasn't injuring herself. What a great opportunity for us as doctors of physical therapy to use our skills, movement professionals, to help a patient start and initiate an exercise program. We're trying to reduce the level of risk or injury or disease. So think about Parkinson's disease is if a patient comes in, we're trying to reduce that progression of the disease through exercise and through discussion on nutrition and their holistic well-being. What's our goal, guys? We want our patients to be as independent as possible for as long as possible and to enjoy their life. So we want to optimize our patients in that pain-free movement. Or if we can't get them pain-free, at least maybe hopefully we get them as close as we can with that understanding of how to manage that pain. There's a lot of different systems out there. So this one's called the 3 R's of rehab. Which I really like because it's going to help you guys. First and foremost, if someone comes in with an acute injury or they want a solution, they're there because they want you to relieve their symptoms. They might not say pain. They might say achy. They might say burning. It might be because they've totally lost the ability to raise their arm. So remember, acute why someone comes in, this is a nice chart because it's going to say, hey, that person comes in, they just sprained their ankle. We're not going to have them be doing box jumps at that point, right? We're not thinking about the third bullet of returning to function. What we're thinking about is trying to manage their swelling, manage their pain, maintain as much motion as they have and they can have, and then just kind of get them back and use a lot of education and motivation to keep getting them to progress on and to get better. Chronic, if someone comes in, this is where we're really applying our pain science knowledge. So we're talking to them about that maybe the acute injury is gone and that we're going to use some of that kinesthetic learning, so movement through body, and we're going to use that to help them gain understanding that they can and they should move, and we're going to apply some of those neuromotor type of techniques so that they start to get better and they're not just living in this constant cycle of pain. Second bullet, restore deficiencies. So this is where we've calmed the system down. Now we think, okay, now I can start to work on strength. I can start to work on mobility, whatever their deficit was. It might be that they've fallen, so you had to address maybe their injury from falling. Now you get to work on balance exercises. And then one of the most fun, but often one of the least amount of time that's spent in rehab is that return to function or those activity specific exercise. So guys, keep that in mind. You can do a lot with the patients at that range. Okay. Therapeutic exercise is defined as that systematic planned performance of bodily movements, postures, or physical activities. Multiple goals. We just talked about that. Remediate or prevent impairment. So keep them moving if they can. Keep them within pain-free movement initially, but then gradually move them out of that. Improve, restore, and enhance that physical function. So how are you guys going to do that? You're going to use all of your techniques. You're going to learn so many manual therapy techniques. You're going to learn a lot of other techniques while you're in school. Hopefully you're going to take a ton of continuing education within your first 5 years, and you're going to really enhance your knowledge here. Then you can also think about the wellness side of things, preventing and reducing health-related risks. Help our patients out, guys. So if someone comes into you with a shoulder injury, but you notice that their balance is off, talk to them about that. Get them in there, keep them coming back, get them believers of physical therapy, because you guys really are going to make such a big difference for them in their whole life. Optimize overall health status. So help them get it to see a personal trainer, get into group fitness, find what they really love, use that time with them to do that. This is a pyramid, but it really should be like this continuum wave where we might start and we address the reason that they're there, abnormal movement patterns. Then we might think about, okay, we got to restore range of motion before we work on strength. But guys, sometimes you have to start working on some strength before you have full range of motion to get to the point where they have range of motion. So this is kind of a flow through this, and it's not only like I'm only going to address their abnormal movement pattern, only going to address their flexibility. It's usually a combination of things. But the top is really where it should be. You should have all of these underneath of it before you start to work on performance. So if someone has a strength deficit, you really need to address that before you're having them do some plyos and agility and speed. So make sure you're coming back to that. This is kind of what I was talking about. I know it's small and maybe you can zoom in on your computer or print it and really look at it, but this is a phenomenal thing. It kind of shows you after the acute management, when you go into phase 2, you're working on these 3 different things. So you're increasing the tissue load tolerance, right? So how much time under tension are you putting that person? That's when you think about the volume of your exercise plan. You're also continuing to address your biomechanics. So making sure that if someone they can time under tension, maybe they can do 10 back squats. But after that, they start to feel tight again. Well, now I'm going to address that. I might give them a mobility exercise or what we call movement snack in between that to make sure that we're addressing that biomechanical deficit. And then we're maintaining general conditioning. So I had a patient come in and he had a UCL tear. So he had to get his ulnar collateral ligament repaired. And one of the first things I told him is he had to do 30 minutes of walking. He was a CrossFit Games athlete. That he had to continue his cardiorespiratory fitness. He could ride a bike, he could walk, that kind of thing. So to make sure that he really, really maintained that. So that as we move down into phase 3 or phase 4, he hasn't lost all of that completely. Plus, you guys, we need, circulation for healing. So what a great way to give your patient that time and effort so that they can come back to that. Key concepts. Coordination, communication, documentation. So we think about coordination. Maybe you think about coordination as far as movement patterns go. I think about coordination with your patient. You need to make sure you're coordinated with your patient, that you guys are on the same team, and evidence supports that very, very much. If your patient is involved with the plan of care, their results are much, much better than if they are not involved with the plan of care. Make sure you're communicating, make sure your documentation. So documentation might not only be your daily note, but are you giving them a good home exercise explanation or plan that they can work on? Are you really addressing all aspects of fitness for them? Or is it every time they come in, you're giving them a new home exercise program? So now there are those patients that come in and they have 20 sheets of paper and they're still doing their exercises from day 1 because it never got discharged. Don't be that person. Make sure you're in charge of your patient for you, okay? Make sure it's at the level that your patient needs for your instruction, and then that you're doing direct intervention for them, meaning that you're demonstrating for them what they need to do, and then you're giving them the tools and the resources for that intervention, and that it directly relates to their goals or their needs, and that it's not just some wacky thing that was written in a protocol. So make sure you're, even with protocols, you're looking at those, making sure those are appropriate. Okay, these are our, Dr. Summers and I, this is our recommendations for you. Okay, designing a therapeutic exercise program. Begin with a thorough examination. We're going to go at that ad nauseum through your musculoskeletal tract. It's a great tract. You guys are going to be very thorough with your exam and with your examination, but understand that's where your development of your Therax program starts. Every impairment you see, you're going to kind of bucket and prioritize to make sure that you're picking kind of what you need to do to focus on for your Therax. You have to match your phases of healing. So again, if we come back to someone who's still recuperating from maybe an ankle sprain and they still got some swelling that hasn't been managed, you might have to go back to the drawing board, think about what you're doing as far as range of motion goes. Are you doing too much? Is that why they're continuing to be swollen? Have you not managed what they're doing outside of their program for you? So keep coming back to that. You're going to use that 30-second snapshot to take a look at their posture, their anthropometrics, their general affect. All of that's going to go into that. You have to have a solid movement analysis. Make sure you analyze the task at hand that they are having trouble with. Then go from there and build your exercise program to be appropriate for that. Bucket your patient-specific characteristics. Are they a mover or are they a non-mover? Are they motivated or are they not motivated? How can you bucket them quickly so that your design can be that much more effective as you move on? We just talked about task analysis. It's really important. And then make sure you keep the end goal at the forefront. And oftentimes you're going to work backwards. If I have someone coming in and their end goal is that they want to return to swimming, well, maybe what I have to consider is swimming is, it's not vertical, it's horizontal. It's in the water. There's multiple different strokes. So what stroke are they having trouble with? Is it cardiovascular? Are they deficit in a cardiovascular type of way too? So I might have all of that, but then they come back down to my evaluation where I look in an isolated manner and I think about those things. And then I start to put pieces together and build my exercise program. So let's talk about Aaron. He's a 40-year-old male. He has complaints of moderate to severe, he's moderately severe and moderately irritable bilateral foot pain. So severe meaning that he can complain of an 8 out of 10 pain. Irritable meaning that once it's irritated, it stays irritated for a while. His first steps in the morning, 8 out of 10. Average, he says, throughout the day is a 6 out of 10, but it never really goes below a 4. So when we talked with him, when we go back to the coordination, communication, and documentation, what are some of the factors that I have to consider for him? Well, he's 40, so he's married. He has 3 kids. He is the owner of a business. So what do you think as far as scheduling physical therapy? Do you think it was easy for him or not easy for him? Yeah, it wasn't easy. We had to talk a lot about prioritizing therapy for him, okay? The instruction for his homework program, we used digital. So we videoed a program for him and he was emailed that. He could download it on his phone and he could follow along with that. That worked really well for him. Direct intervention, so meaning that we, specifically for him, there were key factors that we wanted to do. We wanted to address the intrinsic muscles in his foot, the weakness in them. So we did that through our therapeutic exercise programming. We wanted to address his overall health and well-being, so we developed a program that not only targeted his foot, but he was doing side planks, he was doing posterior lunges with overhead reaches and bicep curls. So we were trying to target all the major muscle groups. Then we also used dry needling to target those specific areas. So that's a key example of how maybe you can do that. Factors affecting your choice. So we talked about phases of healing directly affects that. Movement characteristics, available interventions. So can you guys dry needle at this point? No, you can't. When you can dry needle, you might choose it. Now, if you have dry needles, but you don't have an electrical stim unit that works on dry needles, you can't do that either. So you want to make sure you're working within your scope of practice, which you'll still be very effective, you guys, when you do that. Sequencing is highly important. You might want to think about what target muscle areas are you working on. Do you need to work on the bigger global functional movements because it fatigues your patient out? Do you have a patient that comes in and yes, they would benefit from balance and strength and all of that, but really they need cardiovascular? So you're going to do more of a HIIT type of phenomenon where they're high energy and then they're doing active rest. High energy, active rest, so that they're getting 30 minutes of cardiorespiratory fitness within your thing. And then are you promoting health and well-being? So are you discussing that? Or are you giving them tools for that? Keep coming back to that. So how much exercise does a person need? Do you guys know that? So there's key components. You're going to think about aerobic fitness. So right now, test yourselves out. How many minutes a week does a person need of aerobic conditioning? Okay. And then what do they need for strength? What do they need? When we say strength, we're going to say muscular fitness. What do they need for neuromotor? And what do they need for flexibility? So jot that down, see if you guys know, and then we're going to tell you the answers. Okay. So ACSM guidelines. So 150 minutes of moderate aerobic exercise required a week, or you can do 20 minutes of high intensity 3 times a week. High intensity though, guys, that they're working at that 85% of heart rate max, and that's not changing, and that they can maintain that for 20 minutes. If you can't, then you're not getting it. Muscular strength or fitness, we're going to call it muscular fitness. That's 8 to 10 exercises. So you're trying to hit every major muscle group, 8 to 12 reps, 2 to 3 days a week. Flexibility, this says 60 seconds. Another easy way to think about it is 10 minutes, 3 times a week. So they kind of lumped American College of Sports Medicine, lumped that in. And then neuromotor, they're still trying to figure this one out, but it's so good that they put it in there because it's helping work on that proprioceptive, rich environment for people. So keep that in mind that we really need that to happen. What questions will guide you? So let's think about Aaron. We're going to think that Aaron actually really needs he's not in an acute phase of healing, right? But this has been going on for 3 years. So he really does need a lot of that motivation and convincing and coaching. Plus, he's extremely busy. So if he's extremely busy, what is that going to do for him? Is he going to actually choose to prioritize this now? Well, he took the first step and he came in for an initial evaluation. So that's really a good point for him. Okay. His movement characteristics. So he looked like he was a mover, but when we actually had him go through a lunge sequence, he had extremely poor motor planning. So what that tells us is that he's actually not really ready for multi-joint, multi-activity level, that we had to scale it back before we started adding in medicine balls and throwing and that kind of thing. We want to think about how much skilled PT does he need, right? So that's our promotion of health. And when we think about that, what is he doing in that? Did he need any referrals out? So he's a runner. I want to think about the promotion of health that way. So am I doing everything in my power to make sure that he can do that? And then also, are there any precautions? There were none for him. Okay. Sequencing, we tried to work into his whole 30-minute therapeutic exercise program, multiple exercises that involve the foot intrinsic muscles, yet wasn't a whole program on just foot intrinsic muscles, because there's multiple reasons someone has plantar fasciitis. So we need to think about that and address multiple reasons of that. Plus, I didn't want to fatigue him out so much that he wasn't able to do it. Okay. When we think about the focusing on the patient, we wanted to restore and maximize, motivate, educate, and then also serve as his primary care. So with him, over the course of a 3-week time period, he got significantly better. You can see we're working on his whole body here. We're working on his hip stability, his balance, his core activation through an upper extremity driver. This all was closely related to his desire to be able to run and work out without having pain anymore. So what are our guiding principles? Acute and ongoing. So this is meaning we're going to think about this right away, but also ongoing throughout. We want to always respect the tissue injury cycle. We want to make sure that we're understanding that if maybe even someone comes in ACL, they're doing great, they're doing phenomenal, you've just gotten into where you're adding in a lot more of the functional components where they're doing a lot more thing, and then they come back in 2 days later and their knee is very swollen. Well, you're going to come back to that. You probably did too much. There's an injury cycle that happened in that tissue, so you're going to have to come back and manage the swelling and the pain. We want to maintain and restore. So maintain meaning you want to maintain what they have. So what comes to mind for you guys with that? Have you ever thought about, okay, how many of you guys, someone came in and they had low back pain and they walked in the clinic, yet most of the exercises performed were performed where? Yeah, probably on a table. So if they're able to walk in, so why are we spending a lot of time on a table in a supported position? There are times for that. If they're so severe and they're wincing and they need the support of that, then that's a totally appropriate. But a lot of times we miss the boat with that because we're not even maintaining what they have. We're minimizing a lot of that. So keep coming back to that. Always look at the gait pattern. That might be a huge component to what's going on. And then look at how they control their movement and make sure you can address that. Okay, now we're out of the acute phase. We're going to think about stability of the spine. So think about the core, how you can activate the core through weight, through lower and upper extremity drivers, all of that kind of thing. Strength for the upper and the lower body. Looking at balance and coordination, the cardiovascular system, and then come back to integrating what is needed for life and for sport. So why would you do step-ups with 80-year-old Shirley? What would be a reason? Yeah, so she still is probably going to doctor's appointments, right? She might have to step on and off a curb. So we're training her for those parts of life that she still needs to be able to do. And what would be the worst thing? It would be the falling for her could be a very detrimental thing for her. Make sure you're coming back to that application of controlled stresses. For your phases of healing, I want you to come back to what you are learning in pathophysiology, but just understanding that, again, it's this continuum, but when you're past the inflammatory phase, that we're really trying to tell those collagen fibers what to do and how to behave. So keep coming back to that. Okay? The clinical decision on stages of healing is you want to make the intervention as active as possible, as early as possible. So what would be some of the reasons for that? Okay, so you think about you got injured, you go in, and now maybe I've chosen a lot of passive modalities. So what does that do psychologically to you? Well, that reiterates that you're hurt, that there's damage, and that something is wrong with you. We know that words, the power of words is very strong in therapy. So we want to keep helping our patient understand what's normal and that the body is amazing at healing itself. If I let you do as much as you can, I'm putting the accountability and responsibility back on you, and I'm helping you understand that you do have control, you have hope, you have a participation in our healing together. So you're going to keep that in mind. Okay. Categories of strategies. So what are some active versus passive? So let's think about active is someone they're doing therapeutic exercise with you. Maybe a manual or neuromotor exercise is thinking about doing more of a rhythmic stabilization, so they're participating with you. You can do strain, counter strain, so they're participating with you. Mobilization with movement, that's a great neurological manual therapy technique because it helps the neural system understand what it needs to do. Passive would be pretty much all of our modalities, right? So can you think about any modality where you're active? I'm trying to think. Probably high volt electrical stim. That would probably be one of the main ones that you would do active. But other than that, most of those are passive. Some of our manual techniques are very passive. So you're going to apply those in the different ways in the different stages that they need to be applied in. Okay, some of the pitfalls that you guys might encounter is, let's say Aaron, we go back to Aaron. So he comes in, he has plantar fasciitis. What would be some of the pitfalls we might see is if there's resistance to improvement, meaning that maybe consciously, subconsciously, that he's so used to having pain, he's maybe identified that, he talks to everyone about it, that he wasn't that way. But sometimes you will encounter people that really are just kind of resistant to improving, or maybe just our approach really isn't getting them where they need to go. We talked about this in one of our other lectures, but prolonged pain after treatment. Really, there's been great studies that show you really shouldn't be sore past probably 3 or 4 hours after your treatment. And definitely if you're sore even into the next day, that within 24 hours, you're feeling much better. We see that with dry needling, that there is an expected response often that they'll be sore up to 24 hours. But then after that, they're the best they've felt in a long time. If you have pain after prolonged treatment, then we probably didn't do a good job assessing what? What do you think we didn't do a good job of assessing? I would say their irritability would be number one. Number two would be what their system is like. Is their system one of those that's a little bit hypersensitive? So someone that maybe has a lower threshold of pain, that kind of stuff. So just keep some of that in mind as you go along. And when in doubt, just don't apply as much at the first session. See how they do, then monitor that. Then you can always increase that. We have to help our patients understand that pain is not always bad, but pain is not always needed either, right? Sometimes we think about that. No pain, no gain. So what we want to stay away from is that we're using these scary words. We see that down there, that were these explanations of like, you have this disc and it's bulging out and it's pressing against your spinal cord. Now, patients do want some explanation of what's going on, so you're going to have to do that. What you have to really blend into that, though, is that there is hope for them, that our bodies will heal. Use evidence to support what you're saying, and make sure that we're really considering what the patient really needs to hear. Are they so scared and they need some convincing and motivation that they can get better? Then use that. If they come in and they're not aware enough and they just keep hurting themselves over and over again, then we need to talk about that. Make sure that you're not stressing the system too much, so your volume of your programming might be too much. So that might be something to consider as well. One of the big things is that you've lost sight of function and long-term goals. So if you keep your patient involved, that will probably not happen. Let's talk about pain a little bit, okay? Effective pain education. I love this diagram because it really helps you understand that a lot of times, what's the biggest bubble on there, you guys? It's listening, right? So we're trying to listen. We're trying to use information that they have that is correct or not correct. So someone coming in and saying that they threw out their back 20 years ago and that's why they can't move anymore, that's not correct information. So we need to help them with what's correct and what's not correct. Asking reflective questions. I'll tell you, if one of the best practitioners I know is they're very good at asking reflective questions. Someone came in recently, wanted to have surgery. So the reflective questions involved where the dysfunction lied, right? So do you have pain when you're sleeping? No. Do you ever have pain at a 0? Yes. Throughout the day. Well, so that starts to help your patient go, wait, why am I having surgery, right? Because if they can do all of that and they don't have pain, then why are they having surgery? Okay. You have to tailor your level of health literacy. So some people are going to come in and they have talked to Dr. Google, and they've looked at Dr. Google, and they've watched every YouTube video under the sun, right? And so they think that they know everything. And there's others that have no idea about any type of health and wellness. So you gotta stage that. So take a look at this. Spend some time looking at that. Try to apply it to a case that you guys maybe have seen or that you know. Okay. Use your body's central biasing mechanism, meaning that we're going to help our body move. So we're going to use our kinesthetic movements and learning to show our body that we can move. So we're almost trying to trick the brain, okay? And please always respect pain as an emotion, that just like love means things that are different to you. You probably love in different ways, and people in different ways. Pain is often the same for people. Okay, so let's switch gears a little bit. What is our goal during our acute phase of rehab? Most of the time, it's to control our edema and inflammation. It's to protect our damaged structures, right? So someone comes in, and obviously, if they've been in any type of acute injury, there's damage to soft tissues, might be damage to the bone, cartilage, all of that kind of stuff. So we want to protect those. In our body, that's why our body swells up. If you think about it, it's restricting motion and mobility to create healing. So our bodies are actually really smart that way. We want to progress healing through movement and increase function. So that's why we might use an isometric at this stage. Is more for a pumping action to pump some fluid rather than strength. We're not maybe necessarily increasing strength, but we want to do that. Okay. Take a look at your PT toolbox, thinking about cool and compression. That's the most evidence-based practice rather than cold. Cold is actually not very effective. Cool can be used as an analgesic more so than actually helping the tissue. If you want to get swelling and you want to change swelling, you're going to use a contrast bath. So 2 minutes cold, 2 minutes warm. Okay, we'll use a lot more of our physical agents, manual therapy, and then early range of motion at this point. Okay, early range of motion benefits. What's our strategy? Well, our strategy is to reduce muscle atrophy, right? So we want range of motion. We want as much activation as a patient can give us. We know that right away we start to see type 1 fibers start to atrophy after an injury, so we want to maintain that as much as we can. Try to identify what the patient is able to do and then just keep building on that. So if someone comes in and they can extend their arm, but they can't really flex their arm, then you're going to spend some time doing some extension-based exercises, because even the act of coming back to neutral is building on their ability to flex their arm, okay? Or you might go about different ways where you're going to use active assistive for flexion, that kind of thing. As you move into stage 2, or when you're in that fibroblastic remodeling phase, you're going to think about working in the line of stress even early. So if someone comes in and they have a patellar tendon injury, I'm going to think about working in the sagittal plane. As we move along, I'm going to add in the frontal and transverse plane, but first and foremost, I'm going to do that. And then utilize pumping, you guys. Range of motion is a great way to help fluid move around in the area, okay? Make sure that you're progressing it's during this phase, especially that it's slow, and that you're continually coming back to pain control and tissue healing. You want to get to the point where they have near normal range of motion before you progress them to that subacute phase, and that their edema and swelling is significantly controlled. They might still have a little bit, but you want to make sure that that's controlled, okay? You're probably working on low force and simple exercises, okay? Subacute phase or intermediate phase. So we're thinking now, okay, that acute ankle swelling is gone. They're able to walk. They've kind of normalized their gait. Their range of motion has returned. Now we're going to start to come back and think, okay, they probably don't have any really big, huge, glaring deficits as far as active range of motion goes. It might be near normal at this point. Passive range of motion might be synchronous with pain at when you start to feel some tissue tension. At this point, we don't want our patient to keep picking the scab. So don't keep testing and retesting yourselves. This is where you're going to start your strength and coordination exercises, where we're really throwing that in, and we want to start to think about proprioception and how we're retraining that. So our goals of intermediate is don't pick that scab, meaning please don't. So if someone is like, oh, every time I raise my arm up, it's still kind of sharp at the end. And so they do that 20 times a day, checking to see if they're getting better. That's what we mean by don't pick the scab. So don't keep retesting yourselves in that. You want to move to more active techniques. So they should be much more involved in this. You should be reducing some of those manual therapy techniques you're using. The majority should be therapeutic exercise at this point. And then you want to progressively stress your tissues, adding in multiple planes as you go along. Okay, so our goals: optimize your mechanics, so get them moving how they should move. Look at their gait, look at their biomechanics. Protect the collagen forming, prevent a cross-linking scar. So this is really important when you're thinking about if they're coming in after post-surgery. So just looking at how that scar is forming. Initiate and progress your strength, and then prevent chronic pain. It's imperative that you address that as someone is starting down that fearful tract and fear of movement, that you really address that during this thing, okay? Factors of influence. So guys, when you think about someone coming in and when you're prescribing exercise, you're going to think about their genetic makeup. So lots of different body types out there, and then lots of different experiences. So that environment versus or nature versus nurture. So genetic makeup is hugely important. It doesn't always define you. Their biological age is more indicative of their health status. So keep that in mind. You might have these lovely ladies in there who are just rocking life. Their biological age is much, much less than their actual age. Their health status. Do you have someone coming in with significant comorbidities? Or their training state? Do you have someone like these ladies who's a highly, highly effective and trained athlete at their stage of life? And then their fatigue state. If someone has a lot going on in their outside life and they've also added injury to that, the fatigue factor can be one of the number one things prohibiting them from getting better. So keep that in mind as you move along, okay? The cool thing is there's a predictable pathway for improvement. So we understand that you start probably with passive range of motion, then you go to what? Active assistive range of motion, then you move into active range of motion. It's kind of the same thing when you think about strength. You're going to use isometrics. So now they've done their ISOs, and we do this maybe for pumping, or you don't do it at all, depending on where they're at in their needs. Then you're going to go to concentric. Good. And then what's after that? You're going to start to couple. So you'll do coupled concentric with eccentric training. And then lastly, you'll add in power. Power really, as we age, power is one of the most neglected things that's done for our aging population. So if you think 59 and older, how many of you saw power being worked on in the clinical setting that you were in? Probably not many. So keep that in mind and maybe make sure you're incorporating that for your patient. Okay. We advance to our functional phase when our strength is 75 to 80%. So we want to make sure all those other components are really good to go. Our functional phase is our SAID principle. So guys, what's the SAID principle? So it's remembering that the human body responds to specifically imposed, it specifically adapts to imposed demands. So if you are not training your patients and your clients for their demands of life, then you're not doing them the best service that you possibly can. Okay, keep that in mind. You're going to always come back to the tasks of their daily life and then also of their recreation of their sport. So chronic pain can be very rewarding to treat, and it can also be very frustrating to treat. A lot of times because we have pain without it really a mechanical error, although I think as your manual therapy skills grow and you start to understand tissue and what it should feel like and the response to pain, you'll still feel some of the dysfunction in tissue that way. Faulty mechanics, it may or may not be there. So you might have someone that comes in and you can pinpoint the faulty mechanics and you've felt like you corrected that, and yet they're still having pain. And a lot of times you can come back to that. The excitability of that loop is now what's telling the patient that there's pain rather than there's actual cause of pain. And then overuse injuries, right? So you can have someone who's played volleyball for 10 years and maybe they have constant shoulder pain because of that. So there's a lot of pain science out there, and you guys can actually, there's another course that will offer where you can look more in depth into pain science. But just keep that in mind that chronic can be a little bit harder to treat that way. And we're going to come back to some of our neuromotor motivation techniques. Who's part of your team? So with chronic patients, getting multiple people involved can be very helpful. You can think about someone that might need biofeedback or cognitive behavioral therapy. I've put some things over here for you guys so you can even click on those to see. You can do that on your own, so in case you're not sure what those are. Using mindfulness and meditation is extremely efficacious for our patients, and would recommend you guys do it too. I've recommended that to some of you already. And then acupuncture and dry needling are actually effective with the treatment of chronic pain, and more evidence is growing with that. Postsurgical, we're going to spend another lecture on that. So there's just a little brief touch on when you're thinking of your concept for rehab, make sure you really look at the protocol. Does it make sense? Is there some things in there that don't make sense? A lot of protocols are being reduced significantly nowadays, and there's just bucketing of categories, which is great because we're really the movement experts of the medical field. Really think about what was done in surgery. Like, guys, look at that. There's scissors stuck in there. There's huge mallet where they are hammering in the prosthetic into the knee. You got to think they are going to be extremely sore. There's some soft tissue trauma definitely involved with that surgery. Okay, we're almost done. This is my dad. He had some significant inflammatory process go on about 1.5 years ago. Both of his shoulders and both of his knees significantly hurt. He was cleared for rheumatoid arthritis. Was suggested that he might need some shoulder surgery. He went and had one of them cleaned up, but then the other one started hurting. But you guys, he was extremely resistant to therapy, large in part because it was almost admitting that it was that he was not doing good enough on his own, right? That there was something really wrong with him. So the therapist that he worked with really had to work through some of that, and she had to really come to, am I really getting to what he wants to do, or am I telling them what I want them to do and what I think they should do always and foremost? The minute that he started to get involved with his plan of care, he had choices, it started to go much better. So keep that in mind, okay? On average, you'll have 40% compliance with your patient. That number is significantly less if patients didn't receive positive feedback. Isn't that crazy? So just keep in mind, you guys are also the motivators and the cheerleaders. Use that as part of your education. What are they doing well? What's working well in their body? What looks good? That really does help as we move along, okay? Evidence tells us that promoting high expectations for the final outcome has drastic effects. So if I come in to you and I have complaints of my shoulder and I have numbness and tingling down my arm, if you tell me that I'm going to get better, that you that you really do understand that I'm going to get better. You have knowledge behind that prognosis. You give me reasons why I'm going to get better. That the chances are that I will believe that, therefore I'll get better. Okay. You have to have clear instructions and demonstrate it. It's probably one of the biggest pitfalls when you guys first start to practice is that you're not actually demonstrating what your patient needs. So demonstrate it quickly. Don't give a lot of explanation with that. Address your patient's perceived beliefs on pain and if they're getting better. Now I've started to ask patients, do they feel that they will get better with physical therapy? Puts the onus back on them. I'll tell you that's helped significantly. Keep patients' goals in mind. We've talked about that. Make sure you respect pain, but you're not scared of it. And encourage your patient to participate in problem solving. Okay, lastly, here's our recommendations for you guys. Okay, constantly assess and reassess. So your treatment is your test, and your test is your treatment. So if you did an anterior lunge to assess pain, that might become your retest. But that's also how you're going to design some of your therapeutic exercise. You're going to process through why that anterior lunge creates pain. Can you change that? Can you make that better? Then you're going to retest that. Match the dosage with the demand. So what does that mean? So I have a soccer player who has to play. They barely come out of the game. How long is a soccer game? I think it's 90 minutes. So are you able to keep the demand high for your patient the majority of the time that they're in a therapeutic exercise type of program with you, matching the demand that they need? Or are you not even coming close to that? Okay. Empower through that kinesthetic learning. Help your patient love movement and exercise, you guys. And for them to love it, you've got to love it. So make sure that you find on your own journey what you love to do. Okay. Start with success. Help your patient feel that. End on success. Try not to always never end on a bad movement or a bad one. Use movement snacks. We'll touch on that more. But that's really good if you think about snacking throughout the day. Movement snacks throughout the day are great. Keep the same theme, but add variety. We know our body needs that for adaptations. And use circuit training to add into that. Okay. Okay, so guys, just to summarize it, key characteristics of a good concept for your rehab prescription, is that you are knowledgeable, that you have those principles that you've learned in school, and that you also are self-seeking, that you're not just waiting to be taught for everything, that you're experimenting with things. And then that through your application, through your patient education, through your patient motivation, through all of that, you're using your principles to guide your programming and that you're motivating your patients to get better. Okay, I know this is a long one, and I thank you guys. I'm sure you hopefully took pauses throughout this, but hopefully these will help you as you move forward and you're starting to design your therapeutic exercise program in your overall plan of care.